of a misperception of affiliation?
Sure. Sure, so a misperception of affiliation is, sorry, if I go back to my slides. All right, I'm going to glide through this, and I'm going to give you my favorite way to talk about this is going to be on the interpersonal journal. So a misperception of affiliated behavior might be if you have two, let's say you're in therapy, you're in psychotherapy. And let's say I'm a therapist and I have a patient with BPD, a diagnosis. And I believe I'm acting fairly affiliative. Maybe not overly affiliative, but fairly affiliative. And other people that are observing me would say, yeah, you're pretty accurate. You're behaving fairly affiliative. The research suggests that an individual with a BPD diagnosis might perceive me as being cold and unaffiliative, and then respond to the cold and unaffiliative behavior. There's other research that suggests that it's interpersonal complementary, and it suggests that we will have a tendency and find it easier to respond in very similar ways on affiliativeness to one another. So if I was being affiliative, then the normative social behavior would be to respond in an equally affiliative way. But what we find with individuals with BPD is that they misperceive it. They might perceive it as less affiliative. Or maybe I am being less affiliative and saying, okay, we need to just back off, we need to back off. But perhaps they see that as more of an invitation. So those are misperceptions can go both ways. But given the way that the main effects are, I would say that most misperceptions are that I feel I'm being fairly affiliative, maybe not overly affiliative, and it's being perceived as unaffiliative.
If there are other questions, please raise your hand. Actually, if you have written them down, just kind of once in a while hold them up, send them to the aisles, and our volunteers will run them right over up this way. So I'll take the next one. If there's others, we'll be happy to take them. And the question is antisocial personality disorder the same thing as sociopathic? Is there treatment for comorbidity of antisocial personality disorder and borderline personality disorder?
All right, so there's two questions.
So two questions. The first one is it the same as sociopathic?
Is it sociopathic? Not necessarily. It's kind of two different, antisocial personality disorder is a DSM construct that can have psychopathic qualities in it, but there's also some psychopathic qualities or individuals that meet for that would not qualify for antisocial personality disorder, and vice versa. So there's overlap. Now, in terms of treatment, there are no specific treatments that address the comorbidity that I'm aware of. Perhaps other individuals can speak to that. I think what we do have are treatments that are perhaps modified for settings, but I think that the research that has been done shows that when you have comorbid antisocial personality disorder, then you tend to have worse outcomes. So I don't know that we've really fully addressed that.
We've got a question. Could you explain the difference or define aggression versus impulsivity? Say a little bit more about that.
Okay. So aggression, I think there might be some people that disagree with how I might define aggression. So aggression we might think of as a very dominant behavior. There's different types of aggression. There's verbal aggression, there's behavioral aggression, there's perhaps emotional aggression, but it's a very hostile dominant behavior is how I'd probably describe it. I would have anticipated it to be fairly far up here, and I think that if you look at actual behavioral acts, they can get coded as being very hostile and very dominant. Impulsivity, there are also many definitions of impulsivity. There's motor impulsivity, there's cognitive impulsivity. It's a tendency to perhaps behaviorally act without forethought, without thinking through all the consequences. Perhaps a cognitive tendency to not think things completely through. So that's kind of just brief general definitions I would give of this.
And can you clarify the relation of the concepts of hostility and affiliation?
So hostility would be on the opposite side of affiliativeness. So it's just what I would consider almost a synonym for unaffiliatedness. When we look at some of the hostility measures that are out there that measure hostile traits, and we look at this interpersonal circumflex, they pretty much end up here maybe with a little bit of dominance in them, but they're all considered unaffiliative. So they're perhaps the opposite, the reciprocal end of the dimension of affiliativeness.
We got a question. Can you say a little bit more about the demographics of the subjects in the CLIPS research?
The demographics, yes, I only went over that briefly. So the CLIPS study is a multi-site collaborative study. One of the sites was here at Yale, of community and outpatients. So some of the individuals were seeking treatment at one of the sites. It was Yale, Harvard-McLean, Brown, and Columbia were the 4 different sites. And the individuals were brought into the study because they met one of 4 PDs, or the major depression control group that I mentioned. And the 4 PDs with borderline personality disorder, avoidant personality disorder, obsessive-compulsive, or schizotypal personality disorders. The demographics, they were, I believe, the mean age at intake was around 33. There was a greater diversity of ethnic minorities than you would generally find in those particular locations, but still the majority of them were Caucasian. With regards to the BPD patients, there were more women than there were men. And that's probably a very important consideration because we also then see different gender demographics with regards to forensic settings. Oh, and we followed them every year for 10 years, so that's where a lot of that data came from.
The next question is, can you say how BPD compares to the general population of forensic settings, individuals with high dominance and low affiliation? How are BPD individuals, how do they compare with kind of general forensic high dominance?
So the study, let me go ahead to this if I can. So that study that I presented on the traits in general showed that, this one, yes. So hostility was associated with BPD. So if they had BPD symptoms, then they were more hostile than the general population. And this was the 1,000 male inmates that underwent this assessment procedure. So they did not necessarily have psychiatric diagnoses. They were just being assessed as part of the admissions process for this study. So in general, BPD patients were more hostile than the general inmates in this study. And unfortunately, that's about the only research I know of with regards to those two dimensions. This is an all-male.
Okay. And thank you very much, Dr. Yale-NEABPD.